So, a very warm welcome to Dr. SUDHANK Bharti. Sir needs absolutely no introduction. He's our next speaker, and he's the chairman and medical director of the BHARTI Eye Hospital in New Delhi. He has amazing pearls and he has amazing videos. He has been teaching for decades now, and we'll also benefit in this program from his amazing videos. A very warm welcome to you, Dr. SUDHANK Bharti, sir.
Thank you, Dr. Satyajit, and thank you, Chitra, for inviting me to this wonderful session. And I'm loving it since the beginning. So I'll be starting with my video. And can you see it?
Yes, yes.
Yes, sir.
So I'll be talking on PC rupture, the management of all kinds of PC rupture. And it has got sound, so I may not need to speak at all.
A small posterior capsule defect without disturbance to vitreous can be converted to a posterior continuous curvilinear capsular axis using a specially designed forceps which can enter through a side port without disturbing the antechamber, causing shallowing of the antechamber. Antechamber is filled with dispersive viscoelastic and capsular axis is grasped repeatedly, and a small increment in rhexis size are done to provide good control on its size and shape. A single piece IOL is injected and gently maneuvered into the bag. Here is an interesting case of femtolaser cataract surgery. The main port is opened and visco injected to reveal a free floating capsulotomy. A routine maneuver to manage the nucleus is done with the default phaco settings when a posterior capsule defect is recognized. This is presumably caused by the laser cutting beam up to the posterior capsule. Now, special care is taken that the vacuum buildup is minimal during the cortical removal. A single piece IOL is injected, allowed to unfold itself in the antechamber. And gently slide it into the bag without disturbing the posterior capsule and vitreous. In a large posterior capsule defect, as in this case, a structured disciplined approach is required to be implemented in these challenging situations. Maximum cortical matter is removed by aspiration. The retained cortical matter is the main cause of subacute chronic endophthalmitis and should be removed as much as possible. Special care is taken not to hydrate the vitreous. A specially formulated preservative-free triamcinolone acetate is injected from the side port into the antechamber to identify the vitreous. Anterior vitrectomy is repeated to remove the vitreous tags stained by the triamcinolone completely. A 3-piece intraocular lens is inserted and placed into the sulcus. It is dialed in front of the capsular axis. The optic capture is done with the anterior capsular axis. The viscoelastic is removed from in front and behind the intraocular lens. The capsule rupture can happen in hands of any surgeon. A planned approach is likely to get better outcomes without long-term complications. A dispersive viscoelastic is better since it is not sucked en masse and more often absorbed through trabecular meshwork, causing lesser incidence of raised IOP. Vitrectomy may not be required if vitreous remains undisturbed despite the size of posterior capsular rupture. Vitreous incarcerated in this section leads to retinal tears, retinal detachment, and endophthalmitis. An anterior vitrectomy is better for anterior segment surgery, along with staining of vitreous with triamcinolone for better visualization and complete removal from anterior chamber and corneal sections.
Thank you, Dr. Bharti. That was a lovely teaching video, and we'll be seeing different polar cataracts, but there is always a different tip to learn each time. Having seen your videos, you brought about this talk about creating a PCC in a posterior polar cataract. Now, we all know that the posterior capsule is going to be thinner, 4 to 6 micron, and more elastic than an anterior capsule is, which is about 14, 16 microns. More so in a polar cataract, but the posterior capsule is actually supposed to be quite ready to slit vertically rather than its usual round. So this chances of doing a PCC in a posterior polar cataract gets limited to a fewer situations only, not commonly all. And if at all you were able to do a good PCC, would you want to only implant your single piece in the bag, or would you even consider availing of that Berger space and doing a posterior optic capture in a polar cataract?
Thanks, Chitra. I personally would always, if it is possible to implant the IOL in the bag, I would still prefer a single piece IOL because of the centration issues at a later point in time. But if it is not so well, placed so as to, kind of put the lens with the PCC, I can always do a anterior optics, anterior haptics, and then posterior rexis to be used as a optic capture. But personally, I would always, if it is possible to implant it in a bag, then single piece will be my first choice.
Single piece, I think, might be risky in polar cataract if there is a little big vertical split, because it tends to be a little more bulkier and the PC could give way.
No, so we didn't talk about the split. We didn't talk about that, because in that PCC, if there is a visible posterior, possibility of that posterior long split, then in that case, I would prefer Kiran's technique of making a oval rexis and then implant the lens along the opposite side, so that that's the best thing which I have come across to manage the IOL placement if it is a vertical tear or a long tear. So then in that case, rexis plays a major role as to how to place the lens vertically and nicely, because that rexis gives me wonderful placement of the IOL.
Nice to have you joining us, Gaurav.
Yes, ma'am. Thank you for inviting me, ma'am.
Point.
Yeah, so
in your second case, sir, you have showed that you have done vitrectomy with triamcinolone before putting the IOL. Is that your usual practice, sir? Or would you also recommend that after putting the IOL and then after constricting the pupil, then whatever vitreous is there in the anterior chamber, then we can stain it with triamcinolone and then do vitrectomy?
No, I always put it before. That's the normal way I do it, because I don't want to have any tag of the vitreous remaining, and then causing traction and all those issues. And a majority of times when you're doing a vitrectomy, there's no possibility of upthrust from the vitreous. So if you have done it properly, and it is anterior vitrectomy, not I'm not going back and I'm not moving my probe a lot. So I think for me, anterior vitrectomy, with taking care that you don't tear or you don't damage the iris or the other things, the capsule and everything, I think my technique is to do the vitrectomy with the triamcinolone first, and then And in all these cases, you need to have a optic capture with the rexes. That's what I'm doing as a routine.
Dr. Gaurav, what would be your take on this?
Yes, Satyajit, actually, I would also do a small limited vitrectomy if I notice that, I usually, if there is no vitreous presentation, I would not even do a vitrectomy. I would just do a primary posterior rexis if it was possible. But if vitreous phase is already broken and it's disturbed, then obviously, I would want to do it initially at that point, and then towards the end, making sure that there is no vitreous left, with translucent staining.
So you would do it twice.
I could do it twice, as and when required. I never hesitate to do it, at whichever point vitreous is disturbing you. You should not continue to operate if vitreous phase is already broken and some of it is coming into the anterior chamber, just hoping that you'll manage somehow. I would always interfere right then. But the other thing I thought was, Bharti sir, I wanted to ask that in the first case which you showed where there was a femto, you thought there was a femto, laser causing the break. Was that a posterior polar cataract? I missed that bit. And whether if it was a posterior polar, then what was the reason that you got the posterior capsular break? Or if at all, if it was not a posterior polar, then what might be the reason that we got this? Because, it was heard only right in the beginning when femto started 7, 8, 10 years back that we would get this. Was there, we usually leave a safe margin,
This is one of those cases, I think one of the first 50 or within 10, 15 cases. And I realized that this cut was primarily made by the femto itself when the whole thing began. And since this gentleman was not very old, so vitreous phase was very strong and it was not broken. And I could see that there was no vitreous presenting. And I realized that it was a vertical cut as if it was cut by the femto laser. And, this was one of the few cases, like I've seen a couple of cases where the rexis is not in the rexis plane, it's behind. And sometimes the whole, complex of the laser cutting is slightly behind, so the rexis is not complete, and then there's a cut in the posterior capsule as well sometimes earlier. Now these OCTs are so accurate and everything is so perfect that you don't get these things, but this was very early, first few cases of mine, and this happened. This was cut.
Thanks, in fact, that was what I wanted, take-home message that, nowadays we don't get to see this, and this was right in the beginning. So I'm sure this was amongst the first few cases.
Yeah.
Thank you, sir.
I wanted to clarify for the audience, I wanted an answer from the expert panel. What should be your ideal offset which you would use in a polar cataract so that you're truly safe from getting into any situation?
I use 800 microns. That's
I keep 800.
500 micron was, I've for the normal cataracts, I've got it down to 300 microns. But anything above 600, maybe 800, depending on preoperatively, if I see a very thick PPC chunk there, I would make it to 800, but obviously always over 600.
Ma'am, another change, I think.
Up to 1000.
Right. Ma'am, I wanted to suggest that other than the offset, it's important also to decrease the number of passes and decrease the energy so that, you're using a technique of segmentation where you're not, going on for too long at high energies, because that causes cavitation. I mean, that causes the bubbles to form and that can expand the bag. So I use, a single pass, as Dr. Chi has explained, and it's working beautifully well last few months for me. And, using the right energies and shorter times and lesser bubble creation also is going to be very helpful in these cataracts.
Very nice. Thank you very much, Dr. Bharti. That was a wonderful discussion.